Partner will be joining us a little bit after 10, and I'll be chairing the meeting over to her when she arrives. And first, I am going to start with the roll call. So I believe I saw Greg Clauser. Greg, are you here?
I am. Good morning.
Good morning. Chicky Flowers, are you here yet? Not sure I saw Chicky yet. All right, I'll circle back. Now, Andy Foltz already texted me. She's here. I see her on here and she's driving, so I'm not going to ask her to verbally say she's here. We know she's here. So Andrea Foltz is here. Kimberly Hendricks, I see you. Welcome.
I'm here. Thank you.
Good morning. Sean Parkman, I believe I saw you too. Sean, you with us?
Morning. Here.
Morning, Sean. And Emily Wong. Emily, you're here, yes?
Yes, I'm here.
Good morning.
Good morning.
All right. And I don't believe I saw Representative Rob Nose. I understand it's the first day of session. Want to double check. Rob Nose, are you with us? I guess as he is excused today. And then I'm going to circle back to Chicky. Chicky, are you here? All right. So we do have quorum. Has anyone reviewed the minutes and have a motion to make about our December minutes?
I can make the motion to accept that.
Great, thanks, Greg. Kimberly?
I'll second that.
Thank you, Kimberly. All right, on approving the minutes. Now, Andy, I know probably can't come off mute. See, Sean, how do you vote?
Approve.
Emily, how do you vote?
Approve.
Chicky, have you joined us yet?
I have. Good morning, and I vote to approve the minutes.
Great, thank you. And we have a quorum, and Andrea will just leave as not voting because she can't speak, but we do have enough people who have approved the minutes. So thank you for that. All right, so we are going to get started with the utilization dashboard this morning. That's something we do every year as we head into changes for our next plan year. We have Emery, who's going to be going over that with us, Emery from Mercer. Emery, you here and ready to lead us through this?
Yes, thank you. Thank you, Vice
Great,
Chair.
thanks so much.
All right, so yes, the utilization review, it kind of gives you a preview of essentially how the claims have been running. So it's, gives you a look at where we might be moving into the 26 renewal. So let's move on to the next slide. So a lot of the similar topics that we've been presenting, just kind of going through overall cost, taking a look at the trend, the risk of the plans, and how that translates to the cost of services, and then some deeper dives into clinical and other utilization trends in this case. So moving on to the next section. One more slide, please. Just to level set on the time period we're talking about. While the 24 calendar year has just ended, since we look at incurred claims, we actually have a little bit of a delay in the claims that we're looking at. So we're actually looking at incurred claims through June of 2024. So the time period for the current period there at the top is July of 23 through June of 24. It is a little delayed. There's been some, I can talk a little bit about where we've seen claims, but generally, it's not too different, but there is, I think, a little bit more of an increase recently compared to prior months. 1 year prior is going to be the fiscal year for 23, and then we do show some slides with 2 year prior, so that's July 21 through June of 22. The plan, we show all of the medical plans. The fully insured plans are the Kaiser plans, and then all the others are self-insured. And we do have some additional costs and rebates taken out of some of the slides, and I'll go through that in some detail, but Kaiser utilization. When we talk about some of the standard reports, some standard slides, some of them don't include this integrated care fees. They do total about 28, almost close to $30 million per year for Kaiser. We will note where it is included on the aggregate cost. They are included there, but some of the other slides, they are not. Okay, moving on to the next section, the aggregate cost. So this first slide shows the self-insured total costs there at the top, 2 years prior to the left, 1 year prior is kind of the second column, and then you can see the change between fiscal year 22 and 23, and then the columns on the right are the most current time period. So right now for the self-insured plans, the total costs, excluding admin, but also including the impacts of rebates, pharmacy rebates, and medical rebates, it's about $867 million. That's about a 7.7% increase over the prior year in total. If you look at the bottom line, the enrollment has been growing. Has been growing for PEB, and it has been growing for the self-insured plans as well. So about 4% increase in employees and 3% increase in members. So overall, that 7.7% increase, actually, when we take a look at it on a per employee basis, which is how we look at it when we look at the renewals and the composite rate, that actually results in about 3.6% increase, which is exactly the same as it was last year. For last year. So you've been increasing about 3.6% over the last 2 years for the self-insured plans, which is just above that 3.4% limitation. So overall costs have been pretty close to where PEB is limited to on a self-insured plan. So that's pretty good. But the costs, they continue to increase, and they're, we'll see where the overall composite rate changes next month. In this case, when we do the initial round of renewals. Okay. Please interrupt me if you have any questions, but moving on to the fully insured slide that you can see here. The costs have increased a bit more for the Kaiser plans compared to self-insured plans. So in the top right, you can see that the medical costs have increased about 12.4% total and about 8.6% for prescription drugs. So it blends out to about a 12% increase in total costs. Enrollment does continue to increase, so that's about 3.3% on employees. But still, with the 12% overall cost and the 3.3% increase, that kind of results in an 8.3% per employee cost per year increase. And you can see it's a bit more for medical, 8.8, and then 5.1% for prescription drugs. This does include the integrated care fees for Kaiser, but overall, Kaiser, as you can see, has been, for at least for the most recent 12 months, has been a higher cost increase compared to the self-insured plan. Okay, so next slide. And so in total for PEB, you're coming in, I guess, if you take a look at that middle line, about 4.5% on a per employee per month basis, which is a little bit higher than the 3.4% that was hit for the year prior. So your costs have gone up a little bit. There's some larger claims in November. December, at least initially, is looking okay. But your overall cost increases are probably trending pretty close to where market trends are. And unfortunately, market trends are above the 3.4% limitation. As we take a look at switching between plans and some of the other information that might help provide some potential savings, and as the renewal results come in, that might be beneficial for PEB. However, when we take a look at some of the initial renewal results and the trend rates that are being proposed by the plans, they are higher. And so, just word of caution, the information's not that bad, but, there may be some, we might be talking a little bit about potential ways to make sure that we meet the 3.4% limitation in the upcoming renewal. Okay, before I move on, any questions? Okay, so taking a look at the trend components. When we look at this is on a per member per month basis. So this is a little bit different. We don't include pharmacy rebates, which do reduce the cost in this slide. So that does make it a little bit better, but this is on per member per month basis. And when we look at a per member per month basis, it's a little bit higher than what we were talking about for the per employee per month basis, because there's more employee growth and fewer dependents, at least as a proportion. And so that does make the per member per month increase a little bit higher. But overall, about 6.6%, which is pretty much in line with what we've been using for the medical renewals. And you can see the different components of those in the 4 rows below. So utilization's increasing about 1.4%, which is about similar to where it was for the year before. Unit costs, again, similar story, about 3% increases. And that does vary a bit depending on the types of service you look at. And we'll get to that detail on the following slides. But that's about the same as the year prior. And the member health risk is increasing 1.8%, which is, again, very similar to that 1.7% for the year prior. As mentioned before, we do have more employees. The proportion of employees is growing. Employees tend to be a little bit older and therefore would be a little bit higher risk. So some of this 1.8% is not necessarily just the PEB members getting sicker necessarily, but it's really kind of a little bit of changing demographics as PEB is growing. Cost share leveraging. So that's the impact of the plan design. So anytime you make a plan change, that's going to reduce the cost share leveraging. Also, large claims can have an impact in there, but generally as costs increase, and if you don't change your plan design, this is going to have an impact on what PEB pays. And the impact there is pretty small, in this case, 0.2%.
Hey, Emery?
Go ahead.
Yeah, just a quick question. With the utilization increase, I know this is just comparing this year to last year. Have we seen a trend coming out of COVID that people are utilizing a little more, getting back to what people should be utilizing, or do you have any sense of that?
So there are some slides that we have on preventive services, and it has gone up a little bit. You're still a bit below the book of business. There's a reason for some of that, but I'll go through that in a little bit more detail. But in terms of preventive services, you are maybe just a little bit below. The PEB is a little bit below. I guess the overall utilization is kind of, I don't know if it's not exactly the same as it was pre-COVID. The types of services, as mentioned there, and I think we talked about this in a lot of the prior reports, behavioral health visits, behavioral health costs continue to go up. Surgeries are kind of like coming back to normal, but preventive services are still kind of, at least for PEB, a little bit lower. And there's some, I don't know, additional services that could be done for that.
Okay, thank you.
So I guess to answer your question, it's not quite where we were pre-COVID.
There's still more
But
work
this
to
is-
do around preventative
Yeah.
care in particular.
Yeah.
Okay,
Yes.
thanks.
But this has been kind of like pretty kind of consistent, at least, for a lot of other plans as well. So we've kind of reached our new baseline potentially.
Okay, thanks.
Okay. And there's there's a couple notes there. I talked about behavioral health visits, and then specialty drugs, retail brand drugs are increasing, which in retail brand drugs, it's the GLP-1s really that continues to increase. And there's been some specialty drug, Skyrizi has been increasing quite a bit. And there's a couple of new higher cost drugs that were some members, I think like basically what orphan drugs, really high unique member patient costs that are in there, at least for this time period. Okay, taking a look at it by service category. The admits, inpatient services are there on the left, and you can see it's not really much of a change. It's actually a little bit of a decrease overall. So the right green column is the overall cost. And that's decreasing 1%. Utilization's actually gone down a little bit. There's been a few kind of like newborn costs that have kind of kept the cost not a little bit higher on a per admit basis, but overall inpatient isn't a big impact. But then we start talking about the other categories. Outpatient services costs are about 5% increase, mostly due to unit costs. Some lab services for Kaiser have been increasing a bit, but overall utilization's gone down on that. So fewer COVID tests, but other services and costs have gone up. But the two columns, I guess, in the middle, physician and RX, those are the biggest increases. With the RX, it's, what talked about, it's probably, what you might expect. Physician services, the cost per service has been going up a bit. But the utilization, again, with behavioral health services and some other services are going up a bit. And so that's accounting for half of the cost increase, but 10% overall for physician services. And then RX unit costs, the more costly GLP-1 drugs are being utilized in some specialty drugs as well in this case. Okay. Taking a look at by plan, some of the biggest increases by the different types of services. And this is just overall per member per month cost increases. So you can see for Providence Choice there at the top, prescription specialty drugs is increasing the most, went up about $10 PMPM, or 16% increase for that type of service. Prescription drugs retail, again, and mental health, other outpatients. So very, very similar story. So again, GLP-1 drugs and behavioral health services are increasing there. Statewide, again, prescription drugs, the GLP-1s increasing there. Prescription specialty drugs, again, those are cost increases. And then you can see outpatient lab services are going down. Some of it's due to fewer COVID tests and stuff like that, but those costs are going down in this case. For MODA, they had some outpatient specialty drugs that really had that went away. There were some cancer services that were higher cost in prior time periods, and now that's not showing up in this time period. But again, specialty drugs, prescription specialty drugs, and mental health services are increasing for them. And then for Kaiser, deductible, the outpatient again, and Kaiser HMO, if you take a look at the bottom right, outpatient mental health services, again, cost increases here. Physician services are increasing as well. And then you kind of had a little bit of flip on the maternity costs here. Kaiser HMO had actually a decrease. They had some higher cost services in the prior time period. But now Kaiser deductible had a little bit of an increase. But overall, the story again, GLP-1 drugs, people are using it for diabetes. It keeps increasing. And then you have some of the others, mental health services and basically impacting overall costs. Okay, next slide. So just kind of an overview on the pharmacy trends. I think we kind of, you can see the numbers on the PMPM costs. We do show essentially the PBM, the stuff that goes through traditional pharmacy, and then you have the medical specialty drug, professional and outpatient facility down below. And they're all increasing about 10%, low double digits in this case. We talked about ad nauseum about the types of reasons for that. So we can actually move on to the next slide and take a little bit more detail about those drugs. As mentioned before, Skyrizi there at the top is increasing quite a bit in terms of patients. So that's going up like $3 million. And then you start talking about Humira is actually going down, which is row 4, the biosimilars coming in. So that's replacing that. But then you take a look at the, essentially 4 of the top 6, and those are GLP-1 drugs. And so the cost increases, the additional cost number of services, and you can see there on the right, it's just like, more and more members are using it for diabetes in this case. Okay, next slide, please. So taking a look at medical pharmacies, these are essentially the specialty drugs that are provided in a medical setting. Oh, Sean, go ahead.
Yeah, Enrique, just a reminder, can you remind me currently with the GLP-1 drugs, are pre-diabetic are pre-diabetics currently covered for these drugs in our plans, or is that a decision in the future? Thanks.
You know, I don't.
I can
Go
take
ahead.
that if you want,
Yeah,
Emer.
thank you.
Hi,
Thank you. I was
Sean.
going to ask for help.
Yeah, as of today, there's not an FDA approval for pre-diabetes. So the drugs are only approved through the PEBB plans for people that have documented type 2 diabetes. That there's not coverage for pre-diabetes at this time. Are the manufacturers likely to go for an indication for pre-diabetes in the future? Yeah, probably. But that's not going to happen this year, I don't think.
That's very helpful. Thank you. So yeah, just as we're looking at it, this is type 2 diabetes, strictly
Correct.
speaking.
That's right.
Okay, thank you.
And Sarah, there's like the new indications for GLP-1s, right, with the cardiac. That's showing up, but it's not anticipated to be that big of an impact, if I remember correctly. I could be wrong.
Yes, there's a couple things. There is a cardiovascular indication for the diabetes GLP-1s, and that's already going to be in here. It's people who have diabetes who also have cardiovascular risk factors. What's new is there's some new indications for the weight loss GLP-1s for cardiovascular risk factors, and then most recently, the obstructive sleep apnea in people with obesity. So with the latter, we're definitely waiting to hear from the carriers on how that's going to be handled. That's new news within the last month. For the cardiovascular indication for people with obesity, I think some of the carriers are including it and some are not. I can get back to you on that. But I don't know that it would show up in this data because that's too new.
And can you remind me the code speak when we say indicated? Are we saying that there's a additional risk factor? Yeah. What does that mean?
Yeah, and indicated means that it is the FDA has approved it so that the manufacturers can market the drug for that specific indication.
Okay.
It's been proven safe and effective for the FDA.
So you could have diabetes, type 2 diabetes, or you could have certain cardiovascular profile or what have you, and you could qualify in either of those. Is that right? Is that what you're saying?
So if you have type 2 diabetes, you qualify for the diabetes drugs. If you have obesity plus history of a cardiovascular event like a stroke or a heart attack, then I think with some of the carriers, there is a route to coverage for the obesity GLP-1s.
And sorry for all the questions. I thought
No,
this was
the
a
questions
short
are
one,
good.
it's the same drug though, right? I mean, is it just a different label, right? I mean, is it the same thing, or is there a substantive difference other than the price? For one of them being for obesity and the other one being for diabetes. I guess it's the
Fair
same.
question. Yeah. So Ozempic and Wegovy contain the same active ingredient, and they're made by the same manufacturer. Wegovy has a different dose than Ozempic, so the pens come in different doses. Zepbound and Mounjaro are the same active ingredient and come in the same dose, but they're marketed to different populations.
And they have a different price, do they?
Yes, they do. That's correct.
Okay. And is the diabetes less expensive or more expensive than the obesity one?
On a list price, meaning, the AWP or the stated price, the diabetes is less. There's rebate mechanics that, happen in both of them. But as of today, generally, the diabetes ones are less expensive than the products that are marketed for weight loss.
All right. I think I'm done. Thank you.
Okay. No, it was good. We gave Emery a break.
Yeah. Thank you. Okay. So this slide you see here is the medical pharmacy, so the injectables or the ones that need to be provided in the physician's office. The top two you can see are new ones. Zolgensma, that's for spinal muscular atrophy. That's essentially for newborns or just after the newborns, and genetic testing showing that they potentially have it. It's a one-time. It's a one-time drug, so that $2 million cost should hopefully cure that child or newborn for the rest of their life and be able to live beyond like age 6 or what potentially in this case. And the Von Vendi, it's for von Wildebrands. I messed that up. Okay, so it's a blood clotting disease, and so that's again new higher cost drug that impacting a patient in this case. So some more novel indications here. Some of the other drugs you can see there going on, some cancer drugs and other things going on. So that's going to be a lot of changes, but the top two were definitely new drugs in this case that for PEBB. Okay, next slide, please. So taking a look at the risk scores, so risk scores I mentioned earlier, 1.8% increase. Some of it's maybe due to the changing demographics, changing membership with employees, more employees making a bigger proportion. So risk scores again are to essentially try to provide a kind of a blend of expected cost or expected risk, the costliness of a patient member based on their services and diagnoses. We do normalize to the base time period, which in this case is fiscal year 23, so July 22 through June of 23. So that way you can see the increases from year to year. And the 1.0 is essentially the baseline. So PEBB's increasing back 1 point to 1.1018, or which rounds out to 1.02, and you can see the other plans. Generally, about the increases are kind of similar, 1 to 2%, except for Kaiser HMO, which is there on the second column, which increased to 0.99, which is almost a 6.6% increase in this case. But overall, most of the other plans are pretty consistent. Next slide, please. One thing that we'd like to do with the risk scores is essentially take a look at the cost and normalize it for the risk. So as you saw on the prior slide, the relative risk, relative cost of these members do differ by different plans. And so taking a look at the all-in costs, including admin and rebates and other fees, we want to see essentially what plans essentially cost the least or cost the most for a 1.0 member. And so taking a look at that, that's the line that's moving across. So that's normalized cost, and you can see it by the different plans in this case. The bars are the actual cost, so prior to risk adjustment. So there on the left, you can see Kaiser Deductibles normalized cost is much higher at $709 compared to their underlying cost. That's because the members are pretty healthy. And so, based on the healthiness, you expect to see lower costs. And in this case, that's what's happening. But overall, again, I think similar story to utilization's past, MODA tends to have the lowest cost per risk unit, and they're at 604. Statewide, it's a little bit below Providence Choice, and then Kaiser's coming in higher.
Hey, Emery,
Yes.
thanks for sharing this slide. So is this data based on this last year of claims, not the projected increases?
This
Okay.
is historical. Yeah. So this is again through June of 24 in this case. Okay. Any other questions? Okay. Next slide, please. So taking a look at some top clinical conditions, we have the top 20 essentially episodes or conditions for members. And then we have the 2 years, the most current time period. This one's actually through July of 24, slightly later data than what was shown in the prior slides. And then we have the year prior, so July of 23. And number one, in terms of cost, diabetes, with the GLP-1s and other drugs and costs and the prevalence, is pretty high. So overall, diabetes continues to be the top clinical condition. Number two is pregnancy, which you might, that's to be expected. And then neuroses, which, behavioral health conditions is third. And then some of the others. This really doesn't change too much from time to time. You do see, if you go down to row 6, newborns are pretty, again, pretty high in this case. It is compared to the last time period. It wasn't ranked 6th last time period. I think that's incorrect. But you can see the costs have gone quite up, basically almost doubled in terms of the cost. There have been a lot of preemies that high cost preemies, at least in this time period, and so that had a bigger impact on the inpatient services in this case. Okay, next slide. Taking a look at the prevalence of the conditions, again, taking mental health services there at the top. The increase, it continues to increase generally for most of them, to 10%, depending on the type of condition you're looking at. MODA with depressions at 10, anxieties, 7% for MODA, and then 2 to 3% for the other plans in this case. So there's the increase in the mental health patients receiving mental health services hasn't been spiking as much as it has during the prior years, but it still continues to increase, and the number of services that they're using continues to increase in this case. Cardiovascular conditions is the next bucket. It's kind of varies by the different plans that you look at. Some decreases, some higher. You can see that for Kaiser, actually, hypertension is not as prevalent as the MODA statewide and Providence choice plans in this case. And then down, diabetes is the 4th section, and obesity. These number of patients who are seeing services for these conditions continues to increase. So this is, some pretty big increases there in diabetes and obesity, which, that apparently is leading, probably correlation to GLP-1 drugs being used. And this has been something we've been seeing for the last few utilization reports. Okay, next slide, please. Oh, go ahead, Sean.
So I think I might ask this question every year. I don't remember, but these percent changes, I think my question is, do we have a similar analysis where we're following people who, only a cohort of people who stay in a plan over at least a year? These analyses here are just sort of like, as it so happens, who is in the plan, and then what do they look like? What does the whole population look like in that plan later? As opposed to more of an analysis related to active management. In other words, if you're in a plan longer, does that plan, how effective is that plan at getting on top of your chronic disease, basically? Do we have that kind of analysis, like a trend only considering the same people who stayed stable? It's a little wonky because there's a lot of moving around, but there is a group of folks who stay.
Yes.
Yeah.
We definitely have looked at it. I can't remember the last time we presented that information for continuing members. It was a few months ago. So in terms of, I'll have to check, but we have done it. In terms of the risk score, it's higher than what you see, the 1.8%. I think the annual risk score increases were in that 6% range for continuing members. The costs have been increasing, I think about, if I remember correctly, about 8%. So a little bit higher than the risk scores. I thought you were going to go at these, the clinical conditions and the change in the clinical conditions. I mean, that's something that we may want to do, take a look at over the time period, these continuing members and these conditions to see, how the prevalence, they've been treated and potentially the risk score differences based on how they're being treated. So that would
Right.
be one next
Yeah,
thing
that's
that
kind of what
we,
I'm getting at. Yeah. I mean, some
yeah,
of these we don't cure them, but theoretically their acuity would
mhm,
change potentially.
yes,
And therefore their long-term costs, maybe.
yeah. Yeah, we haven't dived into that. So that is something that we can try to do and take a look at. I, yeah, I think in the renewal primer, we talk about some of the HEDIS metrics too. I don't know if there's a way to look at, impact of some of the HEDIS metrics on long-term members. The A1C diabetes, control. That's, one that pops to mind. How well these members managing, is the GLP-1 drugs really, if they're on that, how's their A1C? I mean, so that would require additional data that we wouldn't necessarily have. We would have to go to the plans to ask for.
Thanks.
Um,
I think it
yeah.
would be helpful to see that sort of thing when we're thinking about plan performance and trends over time, because it's sort of like some of what we're seeing are like new members offsetting, and some of the new members are sicker and that sort of thing, which is important.
Mhm.
I mean, we got to keep our eye on it, but also it would be interesting to see that kind of
Yeah.
like how effective is each plan at um managing the conditions. Yeah. So yeah, for what it's worth, that would be great.
Yeah. Okay. Yeah. So there's a couple questions in the chat. So I think Emily asked about upper extremity fractures, and I'm going to ask Dr. Chwang to correct me if I'm wrong. But I think these are broken arms, broken shoulders, and stuff like that. So
Yes.
I believe, yeah. So it's just like your kind of typical injuries there, hopefully. And then Andy had a question. Comparison between normalized cost per plan and member satisfaction for each plan. Um, yeah, so we do have the member satisfaction based on the caps from the renewal primer. I believe Providence plans had the highest percentage, and Moda and Kaiser were both kind of about similar in terms of the lowest, like around the mid 30s for satisfaction, and Providence and Choice and statewide was close, like upper 50s. So in terms of the costs, I mean, it varies, right? So Moda's cost per plan, normalized cost per plan is better, but overall their satisfaction is towards the bottom end, and then Kaiser's kind of towards the bottom end, I guess, on both, and then Providence it's in the middle, but higher satisfaction. But Andrew, I mean, I don't know if you have the presentation open, but just guess that correct?
I do. You got it correct. Yeah, that's exactly right. For Providence, it's in the 60s for the CAP satisfaction score, which we'll
Okay.
talk about a little bit later on, and like you said, Moda and Kaiser a little bit lower.
Yeah. Okay. Thanks. All right. So moving on to preventive screening rates. So this is I talked a little bit about it with Siobhan. So the screening rates, preventive visits, there on the left. You can see it's below, in this case, what Mercer has as a book of business. So overall, preventive screenings are lower. If one thing, when I was taking a look at some of the information from the other slides that are coming up, breaking out by the different plans, Kaiser's a little bit different. The way they provide services is a little bit different. They do have fewer preventive visits that are noted as preventive visits based on the CPT codes for the members. So some of this decrease that you see here, or lower numbers, is really because Kaiser doesn't do preventive visits the way other plans do. So they do have a lot of other types of visits and services done at those times. But overall, when we're taking a look at these preventive screening rates, which are based on certain CPT codes, they're a lot lower than where Providence, Choice, Moda, and statewide are. So Providence, Choice, Moda, and statewide, we're talking probably closer to the mid 30s, and then Kaiser's below that in about 20%. So, so if we want to just compare self-insured plans, they're definitely closer to the Mercer book of business in terms of visits, but overall, with the Kaiser included, it is lower. But taking a look at the screening rates, we have based on the claims here, we do have some HEDIS metrics on the other, presentation, but generally they are better, in terms of breast cancer screening rates increasing and about in line with Mercer, and then colon cancer is higher, while the cholesterol and cervical cancer screening rates are a bit lower. Okay, next slide. So what we wanted to do is, I think we showed some of the regional, or not regional, when we're talking about like, I don't know, equity in healthcare, then during the RFP presentation, we took a look at different regions and different race ethnicities in terms of the services, or not the services, but the costs. And so we broke it up, some of those slides by the different plans in this case. So this first slide takes a look at plans and their preventive visits by region. And this is normalized to each plan's average. So, so Kaiser, in the blue on the left, 1.0 would be an average. You can see that the metro area actually has more preventive services, and that's the same than the entire plan on average. And that's the same for Moda, Providence, and statewide as well. And so Willamette Valley, where Kaiser has this other location, the preventive visits aren't happening as frequently than it is in the metro area. And so when we take a look at some of the other regions, Central, basically all of them other than the metro are below 1.0, except for Moda in the Central Oregon region. So the types of, there's definitely some differences in the way members are using services. Didn't look into exactly the reasons for this, but once you get into the coast or the rural areas of Oregon, preventive visits are lower. So there's probably a need to try to address what's causing these members not to have preventive services as frequently as those in the metro urban areas. Next slide. Taking a look at the membership by race by the different plans. So Cheeky, you just typed a question. We can take a look at that in terms of in-network providers. I don't have like the percentage of or the providers per like 1,000 members and stuff like that, to really get at what's truly access. I mean, I think we would speculate that rural areas would have harder access, more access issues, and that might be causing some of this. But I don't have the exact answer to that. So taking a look at the membership by race, I think we had talked about the metro area having more Asians and Black African Americans. And if we take a look at the enrollment down below, you can see for Kaiser, they do have a higher proportion of members of color compared to the other plans, especially with the bottom couple, or actually two of the bottom three columns, which would be Asian and Black African American. Some of the other races are kind of similar across the board. Fewer white members in Kaiser compared to the other plans, but the other plans are more in the rural areas, which probably has more white members or population in this case. So overall, it might be tied more to where the plants are located than any other sort of demographic in this case. But when we take a look at the next slide, taking a look at the risk by race by plan, the American Indian, Alaska Natives definitely have higher risk. And as you take a look, the statewide is kind of a little bit of an outlier there where their risk is quite a bit higher. But then we take a look at the other races. White is the third from the right. They're kind of like in line, I think typically a little bit higher, but kind of similar across all the plans. But then when we talk about Asians, Black African Americans, and some of the others, there's definitely a bit of a difference in the plans that you have and the risk. So for Asians, MODA has higher risk on average. Kaiser's pretty low. But for Black African Americans, Kaiser and MODA have higher risk than the rest of PEBB. And so some of the other Native Hawaiian, other Pacific Islanders, a little bit of a difference there as well, with MODA having higher risk. So the risk of the members by the different plans, it's not monolithic. And so how these plans probably should try to address healthcare, depending on the members, taking a look a little bit more into it. I think it's been happening, but people do access care differently. And the races, I don't know if it makes a difference, but there's some stuff going on there, as shown on the next slide, which is the preventive visits by race. So taking a look, again, normalized to 1.0, Asians tend to have a lot of preventive services. But then you start taking a look at some of the other races, Black African Americans, Kaiser's having, they're getting a lot of preventive services, but then MODA's actually quite low. So taking a look at some of these other races, MODA had high risk scores for Black and African Americans, but they're not getting preventive services nearly to the same level as the other members in the plan. So something's going on where, it's not, these members are not accessing care quite the same. And these Black African Americans tend to be in the urban areas as well. And so urban areas tend to have a little bit higher utilization of preventive services. So it's actually, it's a little bit more stark in this case. So there's definitely some differences in how these members are being treated. And hopefully, some of the questions we're going to ask in the RFP is going to, try to see how well plans are doing to look at these disparities and potentially address the care level, the care that these members receive, because it doesn't seem, at least based on this simplified glance at the data, that care is quite as equitable as it could be for the PEBB members. Okay. Taking a look at categories of service, the executive summary, I think some of these we did talk about in the past, but inpatient cost per admit is going up a bit while utilization's not that much. Outpatient office visits, to talk about the costs going up there. Emergency room, so visits remain pretty steady, but the cost per visit's increasing. Generally, lab services and costs remain flat, although there's an outlier, and then GLP-1 usage continues to increase, with the prescriptions increasing over 50% over the prior time period. But looking in detail on the next few slides. Next slide, please. Again, I think inpatient facility admits actually is going down 3%, and allowed per admit increasing about 4%. So cost per admit increased the most for MODA and Kaiser HMO. And the note there about neonatal services, the cost doubled. The cost per admit will increase 40%, and number of services or neonatal admits doubled. So I haven't looked into, I don't know if we would be able to look into why, whether it's bad luck or if there's something going on with prenatal care that's causing this to happen. Hopefully the doulas will help in terms of, preventing preventing some of these extreme neonatal services. But, that has been an issue, at least over the last 12 months. Next slide, please. Outpatient office visits. So overall, the visits are increasing a little bit. Behavioral health services increasing. And then outpatient allowed has been increasing quite a bit, or not quite a bit, but it has been increasing 6% in this case. Down below, the established patient visit costs per visits increasing between 5 and 8% across all of the plans. So the primary care providers are getting paid a little bit more, but it is having an impact on the overall costs. And then some other, so another note there about critically injured young children. When we're taking a look at, this was one of the big drivers. It's just oddly, I don't know if it's oddly, but the high cost evaluation visits increased quite a bit in this case. Cheeky did have a question. Availability of in-network providers of color. Andrew or others, I'm trying to remember what information we have on the race ethnicity of providers. I remember it's like kind of, I think we've had issues getting that information. I don't know if you remember off the top of your head as well,
we did.
but
Yeah, I
ahead.
think that's right. We did post some questions in the round one renewal request to try to get at that data. I don't think that we got specific data for that. I know we got some for like behavioral health and some more specific focused network questions. So I think it would probably need to be a follow-up with the carriers.
So so hopefully we can get some additional information on that. One of the things with the Teladoc primary care, the virtual primary care, I think one of their selling points, Modus selling points was they would have a lot more providers of color, which is, it is virtual, but it is a possibility, potentially being able to find more congruence there for some of the members in this case.
And Marie,
Okay,
if I may.
Yes.
Hi, everybody. Dawn Mautner, she, her, and Aya are my pronouns, and I have stepped back in, and I missed this morning. Sorry, my camera's not working at this time. The question that they asked about the RFP and including that information, it would be a useful consideration. I appreciate the conversation, including with language, and it's part of the access and adequacy array of questions that we need to understand and that are changing fast with the inclusion of telemedicine, as you noted. So thank you for that.
And I believe, Andrew, we did have some questions on language, correct, in the renewal request for this year?
We do, yeah.
Okay, yeah, so we're going through that and we'll provide additional information in upcoming meetings.
Thank you.
Yep. Okay, next slide, please. So emergency rooms, I talked about it a little bit in the beginning. The visits are increasing 0.4%, which isn't really that much. I think it had been increasing a bit. It's maybe flattened out, at least based on this data, and hopefully it's flattened out. The cost per visit does increase a bit, 5.4%. It's not really a little bit more on the higher cost services. Did increase. The percentage of level 4 higher did go up from 51.8 to 52.4%. And those, does impact the cost per ER visit in this case, but it's not as big of a driver as it has been in the past. Cost per visit did increase a bit more for Moda at 10% and Kaiser HMO at 6%. So it's not as big of an issue as it's been over the last, I don't know, I think it was last year, a couple years ago, especially returning back from COVID, but some place just to make sure the costs don't increase too much in this case for a not that efficient usage of services. Okay, next slide, please. So taking a look at lab services, services are pretty much flat. The amount per service has actually gone down 1.6%. Generally, due to province choice and statewide, Modus did increase a little bit, but Kaiser's costs did increase a bit for loud amount per lab services. So they're increasing about 14% for Kaiser deductible, 8% for the HMO. Some higher cost services on average increased quite a bit. They're actually a bit higher when we take a look at 24. So that's something to look, just keep in mind. Some of these services are getting a bit more expensive, especially like genetic testing. So fetal genetic conditions, that's, I think, pretty much mandatory now, I believe. Some sort of genetic testing is mandatory for newborns. And so, and those costs are increasing quite a bit. So we need to make sure it doesn't get too high, because it is a relatively highly used service for PEBB in this case. Okay, radiology services, the increase is about 2 to 3% on both utilization and allowed amounts. Kaiser had some increases in mammography screenings, so breast cancer screenings, but it's not huge drivers, but overall it does increase the cost per member per month by about, multiply those together, about 5%. So it is a bit above the 3.4% limitation. Next slide, please. Taking a look again at some of the prescription drugs, same old story, right? Allowed amounts continuing to increase. Scripts aren't increasing that much, but the allowed amounts are increasing as more and more GLP-1 drugs get used. And so those are more expensive. And so it does make the cost overall allowed go up, cost per script increase, as it's going to be shown on the next few slides. So let's move to the next one. So allowed per brand. So this is where we're going to see the GLP-1s, and you can see the cost increase on allowed per brand, 16%. I mean, it's, the script themselves are close. And then this is pre-rebates. I mean, rebates would bring down this impact, but the cost for those scripts are like, what, $800 to $1,000 each or something like that. And so that's going to impact. Sarah, you came off mute.
Yeah, the GLP-1s are about 1,000 to 1,200 a month pre-rebate, and that's in comparison to some of the older diabetes drugs that are more like $20 a month, or there's some of the oral ones that are more like $600 or $700 a month. So it's just people are migrating to the higher cost drugs. That's part of what we're seeing here.
Thank you. Yeah, so the cost, brand drugs, GLP-1s, it's a very similar story. Generic utilization has been increasing. It went down a while, bit due to COVID vaccines being used, which were not generic, being new. But the generic utilization is going up in part because fewer COVID vaccines in this case. And so overall percentage of generic drugs is increasing back up. Next slide, please. And taking a look at specialty drugs, combined medical and pharmacy, especially utilization increasing about 5%, allowed about 4%. It's been higher in the past. This isn't still good. We're still talking about 10%, 9% increases overall, which is above the 3.4%. But it was much bigger drivers in prior years. The allowed cost increase impact on specialty is only 0.5 point. It's at 0.5%. It's 5% if you remove specialty drugs. In the past, that would be over 1%, over 1 point difference due to specialty drugs. So I think the story is now, how does GLP-1 drugs impact the overall cost? And it's actually being higher than specialty drugs in this case. Okay, so moving on to opportunities and next steps. So just taking a look at some areas, mental health services, again, utilization, prevalence of depression, anxiety, and increased utilization continues. So, there's been a lot of work on this, especially with the behavioral health access, PGs and stuff like that. So we will hopefully see see additional help here, but getting providers, I think that's really one of the biggest things, right? We've talked about needing to increase providers. That's not a short-term solution. potentially ask questions about it in the RFP, asking the plans to help out whatever the state can do, other things to increase providers for behavioral health. Health equity, the value of PEB, talked about the delivery, of healthcare and how it's different by different races, ethnicities. I think the plans are going to definitely have to help in this. The providers are going to have to help in this, in addition to, whatever PEB can do on this. Keep asking questions and keep trying to identify issues and addressing those issues in this case. Navigation, scheduling help might help, especially with access of providers in rural areas, and the race, ethnicity, access, what can be done there, whether you have time to do it yourself or getting other people, because you have to plan out quite a bit in advance for a lot of preventive services. Whatever can be done to help increase. We'll just need to work on that. Okay, next section. And then some of these others, I think diabetes, I don't think we need to go over that. Specialty, it's not as big of an impact again, but continues to be a cost increase. Increasing biosimilars, use of biosimilars has helped. And as those continue to come in, hopefully reduce some of the prices. And then the 3.4% rising cost, 3.4% and the rising cost and inflation. So just keeping on top of this, quality driving members to better providers and lower cost providers, whatever can be done around the edges to improve. It's not, there's a lot of states out there. Washington has a legislative concept. Margaret's, I think, on this call, but legislative concept that kind of mimics and expands what Oregon did on 2% to kind of limit services. That can help, but it's a one-time deal. Managing things beyond that, working around the edges and seeing what we can do to improve care overall. And I think we're trying to do it, but it's not an easy task. And we do have questions. Sean, I think you're number one.
Good, thanks. To your first strategic recommendation, I believe on mental health. So definitely increasing the number of providers, of course, long term is part of the deal. And I'm also wondering if you're aware, and maybe in the future, you can take a look at this and just let us know if you're aware of any other plan somewhere in your book of business, or just that you're aware of, that has tried to embrace or augment their workforce with alternative type care, peer support groups, that kind of thing, just like really pressing in on that. Because as you say, like the increasing providers is a long-term thing and definitely worthwhile pursuing, but it's not going to have like a year-to-year effect. So I'm just wondering, maybe in a future topic, you could kind of like look into this, like, are you aware of any literature or other plans or other employers who have really leaned into that and gotten any kind of results, or they ran into barriers and it was like a kind of false hope or something? So I'm just curious what you know about that.
Yeah, so actually, Christy, you want to provide, I think we've been looking into some of this, so I don't know if you want to provide some comments back to Sean.
Yeah, I'm happy to. We have. So I would say across our book of business, for your kind of that first kind of broader look, we do have employers that are looking at alternative approaches. And we're seeing them particularly in certain industries. I will say like healthcare, the industry really has embraced peer support. Oftentimes it is an internal initiative that is being done that, these organizations are recognizing the value of supporting, whether it's a provider peer support or a broader kind of staff peer support program. One thing I will say is there is a peer support program in place right now through the current EAP, but we are seeing kind of different modalities of peer support, again, kind of more of an internal that's happening in different industries. I would say is in terms of the alternative kind of modalities that we're seeing, we definitely see a lot of employers that are looking at kind of broader mindfulness, stress-based kind of approaches, being more preventive. We're also seeing, right now there are a variety of different therapies that are available through the plan. So we are seeing that as well, some of those broader approaches.
Thank you.
Yeah.
Cheeky?
All right, thank you. Can you go to the next slide, please? Okay, so quick question. So pre-diabetes is not currently covered, correct?
Yes.
Okay, so
For GLP-1s, yes.
okay, so is that not a strategic recommendation as a top opportunity for improvement to include pre-diabetes?
For GLP-1, I mean, I think there's a lot of we have diabetic, pre-diabetes programs that are in place, and I will definitely ask for help on that for some of the details. But Sarah, was there something you want?
Yeah, I was going to say, so right now, the CDC actually recommends the diabetes prevention program, but there's nothing in the CDC, there's no clinical guidelines, and there's no FDA approved use of GLP-1 for pre-diabetes. So the recommended, treatment for pre-diabetes is the diabetes prevention program, which is more diet and lifestyle based, and for some patients who have certain comorbidities, metformin. But at this time anyway, there's no recommendation from the CDC or elsewhere for the use of GLP-1 for pre-diabetes.
Okay, thank you. And I have a question not related to specifically diabetes, but I know executive orders are just dropped. They started dropping yesterday and they will continue to drop for a while. What is our timeline or time frame to analyze executive orders from the new federal administration and then impacts to RFP, recommendations for improvement, and all of these things? Do we have time to do? Well, I'm sure we'll have to make some adjustments, but how does that look like in terms of impact?
Really good question. I don't think we have a actual plan written out exactly, but Ollie, I guess I'll let you speak up.
Thanks, Henry, and good question, Chicky. Yeah, I think the process has kind of started. As we're working through these in OHA, and we'll have to confer with our DOJ attorneys on some of these, and but I know that Emery Mercer, has their regulatory folks looking at these as well that provide, their input to customers like us. So I think it'll take a little bit of time, but yeah, that process has definitely started as of today.
Yeah, and our lawyers and regulatory compliance team, they've been looking at stuff since the election. They've been planning on it. It's just what's actually going to happen versus what people say might happen. I think with the public comment, you're worried that things might happen that wouldn't be necessarily beneficial to members. But we are, we're definitely going to look into it and get information as soon as possible. But it is work in progress, I guess.
Okay, thank you. I know we don't have all the details yet, but I know they're starting to, and some of them are pretty drastic. So just wanted to check in on that. Thank you.
Yeah. Any other questions? I think I don't know if this is record time, but I did finish early, which is, I'm going to pat myself on the back now. But any other questions? Okay. And then, oh, Ollie, go ahead.
Oh, I was just going to offer one comment. The numbers, the increases look better, I think, than I was anticipating, Emery. But just a reminder to the board that that's on a rolling 12-month basis, and doesn't necessarily reflect what you will be seeing in the next couple of months as far as renewals. So good to see that, but reality will hit. So yeah, thank you.
Hopefully it's not going to be too bad, but
Yeah.
we will let you know.
Thanks.
Sean, you had raise your hand.
Yeah, I mean, you mentioned this earlier, but just to Ollie's comment, Emery, you mentioned this a little bit earlier, so that's probably it. But it seemed from a non-medical professional that there was a lot of respiratory illness this fall heading into winter, and by a lot, I mean a lot of people, doctors visits and that sort of thing. And I heard, for whatever that's worth, that there was an increase in emergency room visits and that kind of thing related to respiratory health. You know how it's sort of like that mountain. It's like most people just go to the doctor, but then there's like, that group that's a little more acute, so on and so on. So I'm just curious, as I said, I think you said this earlier, but you don't anticipate kind of a, major bump in utilization when we get the next 6 months rolling, as we move forward because of that?
Well, I think Ollie was referring to the November claims, which were quite high. But I think some of it was due to timing. December, at least the early stuff I've seen, is a little bit better. So I think there is a worry that, there might be an increase. What that increase is, I'm not quite sure. I think it was it's been trending pretty close to trend, what the market trends for PEB, which, isn't that bad, but it is about 3.4%. So it's kind of like I don't want to be optimistic. Just want to be cautious that hopefully it's not going to be too bad. I mean, I think from what I heard on like OEB, it's not as, it's a little unfortunate what's potentially happening with OEB. So I hope it's not going to be that bad, but I don't think it's going to be that bad, but there might have to be, again, some conversations done about, okay, we want, not harming the member really, right? But how can we meet the limitation? And so we'll get that information. The December data is just coming in right now, so I can't give you a great preview for what's going to be next month, but I don't know. Crossing fingers. Okay. With that, I'll turn it over to you, Chair.
Thanks, Emery. Vaccination. Thank you for that. Thank you for those thoughtful questions. I think the insights, there are some continuing in the chat about how to think about these data, understand them a little better, and also and use some of these questions in our RFP process are welcome. We have come to a place in our agenda where it is time for a break. So we're a little early, but let's go ahead and do that. Let's take a break now and plan to come back at 11 to proceed. How does that sound, Ali and board? Yeah? Okay. All right. Thank you, everybody. We'll see you back at 11 to get going. Board members, as you come back, please either come on camera or give me a heads up that you are here so that we can ensure we have quorum to proceed. Hi, Greg, Cheeky, Siobhan, hello. Sean, thank you. We got
I'm here too, Dawn. It's Emily.
Oh, hi, Emily. Thank you. All right. There are a few I can't see, but I think that gets us to quorum and it's 11 o'clock. So let's go ahead and reopen the meeting. Welcome back. And Mercer, I'll hand it back over to you. Thank you.
Thanks, Dawn. All right, so we will, I'll actually turn it over to Cindy Bowman to kick us off on the customer service survey results.
Good morning, everyone. It's been a little bit of time since we've reviewed customer service results. So Rose, can you put up the, there we go. Thank you. So you're going to notice as we go through this that we've included the last 2 or 3 years of results so that you can see kind of how we compare over time. We're really excited to be here and have actually gotten really good responses as far as number of responses and also positive responses. So Aaron and Teslin are going to go through the results, but I just wanted to kind of open it up. And then there is a slide a little bit later on that I'm going to join back in and talk about the results. But for now, I'm going to turn it over to Aaron. And just before Aaron gets started, this is specific to our staff. So our benefits team, also our communications and just dependent eligibility, all of the staff involved, and really is not specific to our carriers or providers. So I just wanted to make sure I set the field for that. So Aaron.
Thanks, Cindy. All right, everyone. So we're going to jump into the customer service survey results. I did just want to note that the survey was administered in 2024 between February 1st and February 29th. So the results are from early last year. So from an executive summary perspective, we are sharing results here based on 4 different categories. First is PEBB staff, and the majority of PEBB members are satisfied with the overall service that they receive. This includes timeliness in providing services, believing the staff is knowledgeable, and then also finding staff to be helpful. From communications, definitely very high satisfaction marks on methods of communications used, the frequency of communication, the content that's provided, as well as the effectiveness of relaying messages. For the website, members are generally satisfied, but levels do vary. We found that 90% of members are satisfied with the website. 79% are satisfied with the organization of the website. And sorry, I should say that 90% was around the content. So 79% was around the organization of the site. And 88% are satisfied with the benefits enrollment system, and that's specifically PEBenroll.com. And then in terms of how these results are aligned with the 2022 and 2023 surveys, the staff numbers, those satisfaction rates that you're seeing here for 2024 are slightly higher than what we saw in the previous years. For communication and for website, those were generally aligned, so the numbers were pretty consistent from 2022 and 2023. And then in that last category there on demographics, you can see that most respondents had been PEBB members for more than 6 years, most identified as female, age 45 to 64, and most respondents lived in Marion, Multnomah, or Lane counties. And if we go to the next page, we'll dig into those demographics a little bit more. So just showing how the survey respondents compare to the general population. Generally, they're aligned with the overall PEB population, but there was some discrepancies. Member tenure was long for respondents was longer than the general population. On the gender, about 70% of the participants were female, which is higher than the percentage of the general population. The majority of the survey participants were between ages 45 and 64, which was consistent. And then most survey respondents live in Marion Lane or Multnomah County, and that it aligns with PEB's general population. I do want to make note that as part of the survey, we did include REAL-D and SOGI questions to understand who's impacted by health equities and how to best support the community members. So these are questions that are recommended and deal with race, ethnicity, language, disability, sexual orientation, and gender identity. So that adds about 25-ish questions to the survey, but provides expanded demographic information. I also want to let you know that with the expanded demographic questions and also just general interest in understanding the respondents and how different demographics are show for different results, we are using a new platform behind the scenes called Tableau that allows us to cut data in different ways and see more options around data. So we're happy to be using that so that we can look into the information provided in different ways. So now we're going to go into the specific questions, and I'll turn it over to my colleague Teslin to walk us through those questions. And then Cindy will pop in at one point, and I'll come back in to talk about member comments.
Perfect. Thank you, Erin. Hi, everyone. So I'm going to be going through the exact survey responses that we received for each question. So I want to start by orienting you to the slide and the upcoming data visualizations that you're going to be seeing for each survey question. Here we have the specific survey question running along the top of the slide in purple font. So you can see this first question that I'm going to be walking through is, have you contacted PEB staff for any reason within the past 12 months? Then we show the exact survey responses in the graph below. So along the x-axis or the horizontal axis, you'll see the specific question options that were given to the participants. And then along the y-axis or the vertical axis, we show the percentage of people that responded in a certain way. And then I do want to call attention to our key takeaways box that we have over to the right side of the page in blue font. This is a way for us to just highlight key findings from each question and also give a little bit of context to the trends that we're seeing over the past few years. So to begin, the first question that we asked is, have you contacted PEB for any reason within the past 12 months? And you'll see here the 2022, 2023, and 2024 responses are pretty much identical, with about 75% of people saying that they did not contact PEB and about a quarter of people saying that yes, they did interact with PEB staff and contact them for some reason. I also want to note that for the rest of the presentation, we'll use the corresponding colors for a given year. So purple will correspond to 2022 responses, which is over to the left-hand side of the bar. The middle bars will be 2023 responses in green, and then the right-hand side will be 2024 responses in blue. With that, we can go ahead and move to the next question. So for people who did contact PEB, we asked them how did they contact PEB staff by checking all that apply. Here, the results show that most participants are contacting PEB via the phone, with email being the second most popular way for members to be contacting PEB. However, we did see a decline in the popularity of email for the 2024 survey. The use of other contact methods, which I think is no surprise, being in person, fax, or mail is very low and has been low over the past 3 years. So we definitely see a phone call being the preferred way for members to contact PEB staff. And then moving to the next slide, we asked people what they actually contacted PEB staff about, which could have been multiple issues. So they were checking all that applied in this case as well. Respondents are most frequently reaching out to PEB staff for either open enrollment plan questions or benefits questions or information. And the results are very similar over the past 3 years, that these tend to be the top two most common ways that people are, or things that people are contacting PEB about. We do want to note that we will be running a survey for PEB upcoming in February again, and we'll actually plan to break out that second most popular category, which is benefits information, into medical, dental, and vision related questions. Because we saw in the previous OEB survey that we ran more recently, we actually did make a distinction in what kind of benefits questions people were asking about, and we were able to glean information that within the benefits category, it's usually people asking about specifically medical information. So I think that's no surprise, but we're looking forward to dive into those results a little bit further when we run this upcoming survey. And then we'll move to the next slide. Again, for people who contacted PEB, we asked them specifically if they were satisfied with their customer service interaction with PEB staff in the categories that are running along the horizontal axis. So we asked about the timeliness of services that were provided, the helpfulness of staff, the ability to provide correct information the first time, the overall just knowledge and expertise, the availability of information, and then just in general, the overall service. So you can see these are percentages of respondents who were replying that they were either very satisfied or satisfied. And you see really high percentages across the board, with people being particularly satisfied in the timeliness of services provided, the knowledge and expertise of staff, as well as the helpfulness of staff. We see a pretty similar trend over the past 3 years. However, we do see it tick up across the board from 2023. And then also in the timeliness of services that are provided, we've seen a significant increase over the past 3 years for that category, which is the one over to the left-hand side. I think it's no surprise seeing high marks across the board, given, as Cindy mentioned, like the amazing PEB staff and benefits team and communication teams that are working on interacting and helping members. So great to see, and great to see that the trends are increasing over the years. Let's go ahead and move to the next slide. We went further by asking people if there were any areas that PEB staff could potentially improve their accuracy. And you'll see that at the bottom of the graph, most people are responding that none of the above. So there was no ways that they could identify PEB staff becoming more accurate. And this is actually a 10% increase compared to previous surveys. So it's great to see a 10% increase trend, which aligns, I think, with members being generally satisfied with their interactions, because it's both A, a pleasant interaction, and B, also very accurate and helpful. And then I'm going to go ahead and move on to the next slide, which transitions to specifically asking about PEB's website. So we asked people if they had visited PEB's website in the past 12 months, and looking at the left side of the graph, you'll see that about 71% of participants did visit the site within the year, which is also a 10% increase than we've seen in the previous years. I think great to see that there's more interaction and more people going to the website, given that PEB is linking a ton of really important resources and digital tools for members to learn about their benefits. So that's really a way for them to access all of the benefits tools at their fingertips. So great to see that interaction with the website ticking up over the past few years. And then moving on, we asked for people who did in fact visit the website. We asked if they were satisfied, as Erin alluded to earlier, with the content. So that's like the information that's available, and then also the organization. So are you able to go to the website and find what you need pretty easily? The blue bars here are showing people who responded satisfied or very satisfied, and the pink bar, or the one to the right, is showing responses for unsatisfied or very unsatisfied. And as Erin highlighted, people are definitely very satisfied with the content and also satisfied with the organization, with some higher marks for the content and the information that's available. This year overall, people did report being more satisfied with PEB's website than in previous years, which I think also speaks to more people are interacting, more people are liking their interaction, and continue to want to go to the site and access the site for benefits information and much more. And then the next slide asks specifically about PEB's benefit enrollment system at pebenroll.com. And so again, here we asked for people's level of satisfaction. The blue bar is showing an 88% satisfaction, so really great to see that people are overall satisfied. But this was a new question that we added in 2024 to gain some additional insights, so we don't actually have any year-over-year data available, but great to see. With that, we'll move on to communications. I do just want to pause and see if there's any comments or questions on what we've covered so far. There'll also be time at the end.
Oh,
Yeah,
Emily has a
Emily.
question.
Yeah, thanks so much. It's great to see so much improvement. I just had a quick clarifying question about that website graph, the 21% about ease of finding what you need. Do you all have like a little more detail about what that was about, or is that a more general category checkbox?
It's just, that's specifically for that question. That's all the information that we have. You just rate your satisfaction on a scale. So people, in terms of organization, we're rating that 21% as unsatisfied. Erin and Cindy, I don't think, we also ask for people to write in comments, but I don't actually believe that there was any write-in comments specific to ease of finding organization. Correct me if I'm wrong.
We did have some, well, I should say we have some coded as being related to website organization, but in looking through that, I don't think there was anything super helpful in terms of providing more direction on that.
Okay, thanks.
Emily, I do want to add, though, that this is an area, although we don't have specifics about it, we do sort of have a new template for our website. We just haven't been able to implement it yet, but we're looking at doing that this year. So we're hoping to actually improve that. We recognize, I mean, the organization has been what it's been for years and years and years. And so we're looking at some fresh new ideas and some way to organize the information so it is easier for people, more intuitive, if you will, for people to follow through. So hopefully that's going to help.
Oh, yeah. Okay. Thanks, Cindy.
Siobhan?
Yeah, I really just wanted to make a comment and appreciate the work of the staff at PEB. And my understanding is it's both PEB, they answer questions for PEB and OWEB. So they have quite a breadth of knowledge, and really seeing improvement over time, and also just how satisfied folks are, because it's a lot of work to be able to answer people's questions and their emails, and just want to give a huge shout out to all those staff, and thank you to the leadership too.
Thank you, Siobhan. We are very proud of the staff, and they do great work. And you're right, it's a ton of work. And we have, just as far as the benefits team, I think we have 5 or 6 people who work through back-to-back open enrollment seasons. So we're really proud of what they do, and thank you for acknowledging that. Yeah.
Great. Thank you all so much. Yeah, thank you for highlighting that. So this is switching topics now to communications that are sent out by PEB. So we asked people how satisfied they were with PEB communications in terms of the methods that are used. So this is whether PEB is sending emails or home mailings or the monthly newsletters and learning and events. And then also the frequency, so how often those mailings or those methods are going out. The content, which is just what the topic is about and how we're saying it. And then lastly, the effectiveness. So how well can people really understand the benefits and the information that's being presented. So you'll see here, the blue bars are really high, a 90% satisfaction rate across the board for every category. Members are most satisfied with the methods that are used and with the frequency of communication, so that's great. This is a new question that we added in 2024, so we don't have a year over year, but again, there's obviously a communication strategy in place and something that PEB is really focusing on, so great to see these high marks across the board. And then moving to the next slide. Thank you. In terms of communications, we asked if there are other topics that members are curious in learning more about with the ability to check all that apply. And so you'll see here the top two people are most interested in learning about wellness programs and about core benefits information. These results in the way that the graph kind of cascades down is pretty similar to what we see in 2023 and 2022. Wellness programs and core benefits are always the top two things that people are interested in learning about, but we actually did see an interest in core benefits of 15% since 2022. So that was 2 years ago. So great to see that more people are engaging and learning about their core or interested in learning more about their core benefits. I do want to highlight, because wellness programs is often the top of the graph that we see, PEBB is continuing to highlight and advertise the various well-being programs that are available through the communication. So there is even an online digital wellness guide that people and members can access at any time to see what PEBB's specific wellness offerings are. And a little sneak preview to what Cindy will talk about in a few minutes, that this resource is going to be continued to be highlighted in 2025, because, for example, the 2025 monthly newsletters, which you may have just seen the January edition come out a few weeks ago, these newsletters will be focusing on specific medical conditions, which provide opportunities to highlight the associated well-being programs for a given condition. So hopefully members are interested in learning more about wellness programs, and those will continue to be highlighted in communications. And then the last slide I want to cover before turning it over to Cindy is how PEBB members actually prefer to receive information. And so we see here that email and website are by far the most preferred communication channels. However, the next two, being newsletters and webinars, are also preferred by members. So that's great to see, given that newsletters and webinars are a monthly resource that PEBB is putting out. So it's great to see that level of engagement. And then I also wanted to let you know that for the upcoming survey in February, we're also planning to ask people if they prefer to receive information through digital tools such as the online plan comparison tool, the Explore Your Benefits tool, as well as the wellness guide that I just mentioned. Since these are kind of newer methods that PEBB has been using in the past years, we want to make sure to gather data on people's engagement with those resources as well. But I will turn it over to Cindy for the next slide to highlight some of the things that we're doing in 2025 based on members' feedback for our communications. Thank you, Rose.
Thank you. So thank you, Teslin, really great job. I don't know how many years ago, it's been 7, maybe 5 to 7 years ago. Sean, we're going to give you a shout out here, asked that we really create an actual communication strategy, something beyond just sending out emails occasionally to inform members, but really create a strategy. And so we sat down with Erin and others of the Mercer team, and well, I'm just going to give Erin and her staff all the credit. They created this really brilliant strategy. It was based on, we went out and polled, did focus groups with members, and asked for their insight, and also talked to the board members who were there at the time about what they were interested in, how they wanted to receive communications, all of that. On top of that, the Secretary of State came in and did an audit on our communications and found that we really believed that we should be providing more education to our members so they understood their benefits better and their wellness opportunities. So all that to say, we put together this great strategy, and all these years later, we are seeing it come to fruition. We just added this slide. Actually, it wasn't in the original presentation, and we started talking about it and decided we really wanted you to understand how far we've come from those few emails that we would send occasionally to just this really great newsletter and other ways to communicate. So some of the feedback we got was, boy, it'd be great to do little videos to educate members, look for different ways to do things. So because, you know, members say they want to get things by email, they also tell us they get too many emails, and we also hear a lot they don't read the emails. So we really have been trying to be creative and look for some ways to present information and to educate our members. So in this most recent newsletter in January, we have added a podcast feature, if you will. January's was with a doula, because we've introduced doula benefits this year. We thought, hey, it'd be great to educate our members on what exactly does a doula do? How can you help us? Anyway, we found this really wonderful doula who sat down with us and talked about just that. What does a doula do? So as part of our newsletter now, this is you'll see kind of the format of what the newsletter looks like going forward starting in January. So we have a podcast feature that we'll have each month. This in February, it's going to focus on cancer screening and what members can do if they're newly diagnosed with cancer. And we're going to have Canopy's Employee Assistance Program sit down with us and talk about that. We're also doing short video clips that will align with those monthly topics. And then, of course, we have the well-being resources and point solutions. And as Teslin member mentioned, we have the wellness guide that is all-encompassing. We hope it's all-encompassing and is updated regularly. That includes all the programs and point solutions that our vendor partners, carrier vendor partners have, in addition to just specifically point solutions. So anyway, all that to say, we have been listening to our members and you board members and are really trying to engage and enhance our communication so that members really do feel like they're getting the information they need and understand their benefits better. And so anyway, I would encourage you, the newsletter is out on our website, and if you want to go take a look at it, I really encourage you to do that and listen to the podcast. And anyway, I'm very, very proud of the work that the communications staff does. There are really 3 members, and we work closely with the Mercer team, and as you can see just by listening to them both speak, we have some great resources there too. So I just want to take a minute to say that. Thanks. Okay, Erin, back to you.
Thanks, Cindy. All right, we'll go to the next slide. All right, Teslin, I'll let you finish up with the HEM questions.
Sounds good. Yeah, we just have a few more slides on the specific survey results. So this is switching topics completely to the health engagement model. This next question was, did you participate in the health engagement model for the previous plan year? You'll see over to the left-hand side that a large number of participants are participating in HEM each year, which is very consistent. We're seeing about 85% of survey respondents participating in HEM for a given year. And then if we move to the next slide, for people who responded that they did participate in HEM, we asked them why they chose to participate. So you'll see some responses across the board on the horizontal axis. So this could be either for the monthly incentive, to just being more engaged with your health, to keep your healthcare costs down, to keep your deductible low, all of the above, or just another category that's not listed. So you'll see over to the left-hand side, most people are participating in HEM for the monthly incentive. However, there's plenty of people who are also participating for the other reasons as well. You'll notice towards the right, the all of the above category was added in 2024. We didn't have that before because we noticed that there's probably a lot of reasons why people are participating in HEM. So we do see slightly fewer responses in 2024 for the other categories, given that we added that as an option. And then the next slide was for people who responded that they did not participate in HEM. We asked them why they chose not to participate. And you'll see on the left-hand side of the graph that most people are responding that it was because they are a new employee and they weren't actually eligible. The other options, for example, I'd just rather not, or I'm retired and I wasn't eligible, received very low responses over the years. And this is typical to what we see over the past 3 survey years. So most people are not participating because they were a new employee and weren't eligible. Next slide, please. And then each year we also ask members if they'd like to improve their health and well-being, just to get a general poll of like a pulse if people are interested in improving. And I think it's no surprise that we see a high percentage of people saying yes, they're very interested. And it's great to see just a slight increase year over year in the yes category for people being interested in improving their health and well-being. And then I'll wrap up with the final slide, which is just an additional overlay for you all, additional analysis point to kind of digest this data, is just a demographic sort of related question that asking people about what their medical insurance company was for 2024. So just noting that most people, about 60% of these survey participants, are enrolled in the Providence Health Plan, with about 20% being enrolled in MODA and 20% in Kaiser. We added this question in 2024, so we don't have year-over-year data, but I think it does provide just an additional nice overlay to the data that we're looking at. So I'll go ahead and turn it over to Erin now, who will talk through the write-in responses that we received.
Thanks, Teslin. So we do ask for or include 3 write-in questions in the survey. One is around where areas where PEBB can improve accuracy, where we received 794 comments, which is about 8% of the total responses. We did also ask topics that members wanted to learn more about, and we received 530 comments about that, which is about 5% of responses. And then we have a general, tell us anything else you want to know, comment at the end. And for this, we received 1,687 comments, and which represents about 17% of total responses. So for each of the write-in questions, we go through a process of coding the comments. So code them by topic. We do review all of them, but for easy sorting, we code them by topic. You'll see some of the or you'll see the comments or then the topics on the on the next slides, and the numbers in parentheses indicate the number of comments that we received for those specific topics. And generally speaking, the comments that were received in the 2024 survey were generally aligned with the comments that were received in 2023 and 2022. There was nothing, no outliers or anything new that we had seen. So if we go to the next slide, we'll see the comments about areas where PEBB can improve accuracy. I will not look at all of these in detail, but just go through the top 3 for it. So in terms of areas to improve, the first one is have not contacted PEBB. They're new to the plan, so that was the biggest comment there. But then of actual feedback was around customer service, problem solving, and responsiveness, with 95 comments there. The benefit plans, information or explanation of benefits, 75 comments there. And then next was the website, which was 43 comments. So this is where we noted earlier that we do get some comments about the website, but the information provided wasn't necessarily that helpful in terms of kind of understanding that. So we do, like I said, we do review each of the comments. On the next page, which is where the topics, the topics you want to learn more about. And again, we got 530 comments on here. The top 3 areas of interest were around retirement planning, Medicare, Social Security, etc. So we got 112 comments about that. Next was about the wellness program. So we got 40 comments around that. And then 36 comments around better information about the services provided and using the benefits. And then on the next slide, we'll go into that general kind of open-ended, what else do you want to tell us question. Here we have them broken up into categories because otherwise it would be a bit overwhelming. So in the category of general coverage and benefits, you can see we received both positive comments from members, but also then areas for improvement. On the areas for improvement, the top 3 were around wellness programs to improve health, gym, fitness, discounts, etc. Not surprising to see that at the top in the surveys, and I think in the slides that Teslin showed earlier, and also what we saw in the vendor partner survey results that we had shared last year, that people are interested in wellness programs, want to learn more about it, but are not necessarily, don't know where to go to find information, want to learn more about it. So that is, one of the reasons why we're focusing on them so heavily this year. In terms of the second item there, they want coverage for weight loss drugs, including the GLP-1s, et cetera. And then also want more weight loss programs covered. And so hopefully they're going to be happy after, for 2025, where we have introduced some new options there. On the next slide, we have the category of, we have just an information category and also a claims and billing category. So for these, we received comments and areas for improvement. Top 3 were about the website being hard to use, navigate, or poor online service, which aligns with the results that Teslin shared earlier. People have questions about coverage or want more information about benefits. We got 54 comments there. And then needing more information about retirement benefits and Medicare, 34 comments there, which aligns with what we saw on the previous slide. And then around claims and billing, comments were about taking an excessive amount of time to resolve a claim or a problem, low reimbursement rates, and then too many claims denied. On the next page, we have the category of enrollment. Received some positive comments there. In terms of the areas for improvement, it was about the enrollment website being difficult or complicated to use, information being unclear, unable to see, or not being able to compare benefits, and then wanting benefits to carry over or roll over automatically and didn't think that enrollment should be mandatory. And again, hoping those people were happy that it was a passive enrollment in 2024 for 2025 benefits. And so then on the next page, I can't remember if we have one more slide or not. Yes, this is the last page category. So we have premiums and costs, couple positive comments about it being affordable and good price. On the areas for improvement, seeing the comments about premiums being too high, out-of-pocket costs being too high, and co-pays being too high. And then in the miscellaneous, several comments about people being happy, satisfied, health is good. But then this is where we kind of put all the things that are maybe not related to staff and benefits and communications. But so we had 28 responses that were completely unrelated to health insurance, 17 about the survey itself, and then 10 regarding executive compensation and greed in the healthcare industry. So we note these, but put that in the miscellaneous category. So before I turn it over for any final questions, just want to confirm that we are going to be doing the customer service survey again in February 2025, so next month. We do it during that time frame, so it aligns with the governor's food drive campaign, which we think really encourages good participation in the survey. This year we'll also be doing both customer service and vendor partner comments. So asking about the vendor partners and the plans and telehealth and how often you're able to record or get appointments scheduled, et cetera. And then of course, we'll be including also the demographic questions as well. So watch for that in the month of February. So any final questions or comments around the survey?
Thank you for this work. It's good to have some insight.
Yeah, happy to. Thanks for the partnership, Cindy and team, and the board.
Thank you.
Any further questions? You must have done a good job of answering all the questions preemptively.
Right.
Thank you for the presentation
Yep.
as well as the
Thank you.
work. It's super helpful. Ali.
Yep. Yeah.
Yeah, if I could just make a quick comment, I just really wanted to thank Cindy and the Mercer team. This is a culmination of a lot of work over, really a period of a few years, like Cindy had mentioned, and was an investment that the board decided to make in our communications to really make some market improvements. And we'd be remiss if we didn't also mention our carrier partnership as well as our labor partners. I think that we've made tremendous strides, as kind of a PEBB team for the interests of our members. And it's kind of amazing to see where we've come from just a few years ago. So, and then just our member services team, that's a family that's worked together for many years. You don't see, I think the only turnover we see is retirements, and Those are truly the backbone of our program and our benefit experts. And it's so great to be able to share the good work that they do with the board. So that's it. Thank you very much.
Nice shout out, Ali. Thank you for those. Thank you for that context. It's that's helpful for us sitting on the board as we do come in and we don't have insight visibility into all the workings behind the scenes that it takes to put these kinds of things into motion and then turn around and take the insights and make them useful for those of us who are trying to bring together all of the information, synthesize it. So we'll turn now to Ruby and Brian and look forward to this RFP update. And I will note that we are back on track for timing. So thank you for helping us stay with it. Ruby, Brian.
All right. Thank you. So I'm Brian Olson. I'm the contracts team lead. I use he, him, his pronouns. Ruby had a conflict today, so you're stuck with me for this brief RFP update. Next slide, please. So we just wanted to bring back some high-level updates to you just to inform you of how things are moving forward. We have an updated timeline, as you're seeing on the screen here. We pushed the RFP release back a little bit to approximately July 2025. This is going to give us a little more time to draft some of the template documents, to determine and polish up some of the supporting business processes for the RFP, and also to give us time to, based on both board and leadership feedback, give us a little more time to do a survey or poll of our PEB members, as well as go to PMAC and the Worksite Wellness Coordinating Council to obtain some additional member feedback that when we come back in May or June to the board may change what we end up recommending for the final, RFP structure, design, et cetera. One thing to note, this also shifted when we anticipate evaluators reviewing proposals and scoring. So you'll note that there's a placeholder in winter of 2026, around January of 2026, when we would expect this to happen based on the latest RFP updates. The plan year implementation has not changed. It would still be targeted for 2027, with us really wrapping stuff up earlier in 2026 so we can get the appropriate implementation activities completed. We can do things like system programming of the new plans, et cetera. Any questions so far before I move to the next slide? Okay, next slide, please. This is just a recap that, based on previous discussions, the board has decided to go with option 2, which means there would be fewer than 5 board members evaluating and scoring proposals. It also means most of the evaluator meetings we have, including board members, could be held in private, et cetera. So moving on to the next slide. This is the latest and greatest information about which board members have volunteered for the various roles. I will pause really quick. Are there any, updates to this? Any new volunteers that want to volunteer either today? And also just to note that you can always follow up with Ruby and the Mercer team and/or Ollie and Damien if you do want to volunteer. So let me pause for a minute. Any changes to these volunteers? Okay. So next slide. Oh, look at that. Thought there was one more, but hey. Any overarching questions or concerns? Just one note, if everything goes really well, and with a big project like this, that's always to be seen. But if everything goes really well, you may not see us in front of the full board until May or June, when we'll provide updated information to ask for approval to move towards release. Siobhan?
Yeah, Brian, thanks for bringing this back and for to you and Ruby for working on the timelines. I just want to recognize that you've put in additional time to reach out to PEB members about the process. And just from what we saw from the previous survey around communications, how critical it is to be talking with PEB members about what's coming up. So just really want to appreciate that being built into the timeline.
Great. Any
I'd
other
like to
comments or
echo.
questions?
I'd just like to echo what Siobhan said and acknowledge that I'm not volunteering actively yet, but after I have a chance to work through some additional questions, my hope is to participate, at least in a work group. Sean, I see your hand is up.
Yeah, thanks for the overview. And Brian, I think I ask this question every couple of meetings and like embarrassed that I don't remember it for some reason, but can you remind me on the timeline, we make final decisions apparently in March, let's say. I think the way it worded it was like finalist interviews, apparent successful bidder, and contracting is just kind of like marked as like March.
Could we go back to those slides? I think it's just a couple slides. It might help to have that on the screen.
Yeah, there you go. So can you just remind me like how that fits with the like is it that moment where that's the new plan, finalizing contracting and whatever somewhere around March, maybe April, etc. And then that's the plan that we're offering the very next October,
Correct.
right?
So
Okay.
approximately sometime around February, March, we would do the finalist interviews. Then all the points would be, tallied up, and we would have kind of the aggregate scoring and what all the selection options are based on the RFP rules. We would then go back to the full board, and I don't have the specific timeline in front of me, so please don't hold us to this specific date. But we would then go back to the full board, let's say April, May, or June, whatever the case may be, with the recommended winners. And we would talk through all the options with the board, ask the board to select the final winners. From there, we issue notices of award. We start negotiating the contracts. And you're correct that this would be for the plans that would be available effective January 2027.
Okay.
And the reason why we're having to make selection so early in the year is because of all the implementation activities, system programming, communications, etc.
Yeah, I mean, it's a lot to happen. And I guess as we're really thinking it through, as I was thinking about, adopting rates for the purposes of the legislative budget builds, that agencies would need to know their so that's what I was really thinking about, and that happens relatively early-ish, right? I mean, that happens like by June-ish or so. So I'm just curious. Yeah, I mean, I can do this offline too if this isn't helpful, but I was just kind of curious about like landing the plane, so to speak, at that very last, those last like 4 months when like budgets are getting nailed down, we're adopting rates, and then that sort of thing. So that's my question, really. I see Ali came on.
Oh yeah, just to jump in. So the way that state agencies budget for their benefits is in the budget instructions, which were actually published, probably 9 months ago. They actually take that per employee per month composite rate that we produce, and then they just add 3.4% per year, and then they publish that in the budget instructions as part of the budget bill for the 25-27 biennium. So that's actually already been determined. Whether we can do a reset or whether they will actually do a reset for agencies, based on however the RFP plays out. I guess we'll get that answer at some point. They sometimes revisit in the second year of the biennium, based on circumstances, COLAs, that kind of thing, what the funding looks like. And so we'll see how that plays out, but that's really generally how it's done at the state budget level.
And I could be
Best of-
wrong here, but just based on the updated timeline here at a high level, I think that the general rates would still be known around the same time as we know, as they're finalized in normal years. Is that what, usually June, some years July, but I think usually it's May or June. So, and remember too, there's a lot of information we have up front. So before we get to the point of selecting the winners, one thing we'll be doing is working with Mercer behind the scenes to identify any issues, whether they be, financial or care delivery or other.
Thank you. Any more questions here?
Thank you.
Thanks, Brian. Nice job covering. All right, I think we are moving to Andrew to
Yes.
review the renewal.
Yes, thank you, Don. Hope everyone can hear me okay. Good morning, glad to be with you. Still say good morning for the next 10 minutes. So I think we've got 30 minutes for these slides. This is the renewal primer, and so this sort of formally kicks off discussions around the upcoming 2026 plan year renewal. If we could jump to the next slide, the intent of these slides is really to prepare you all board members for what's to come in the next few months, so that you can be as informed as possible and actively participating throughout this renewal process. And so to execute on that intent, we've set up these slides in two primary sections. The first is current state, which is where we will take a moment, talk about which carriers are renewing, do a quick recap on decisions that were made by the board last year for the 2025 plan year. And then we will shift gears and start talking about 2026, including the approach for this renewal, which is going to be a little bit different given PEBB's participation in CIAO, as well as the medical and pharmacy RFP, which, per Brian's comments, will be a 1/1/27 go live date for the awarded carrier or carriers. And so that is an influencing factor that we don't typically have to navigate with these renewals. And so we'll spend a little bit of time talking about that and how it might interact with these efforts around 2026. Okay, just stop me for questions. I will try to keep an eye out for raised hands, but team, just help me watch out for those, please. If we can jump ahead to slide 4. This is a quick overview of the carriers that are renewing 1/1/26. We've organized this in these columns based on benefit type. And so we will work through each of these carrier renewals over the next few months. There are a couple carriers that do not renew on a calendar year basis, and so we have put a little pink star next to those 3. Those are the standard for life and disability, which is currently in a multi-year rate guarantee, and so that will next renew 1/1/27. Unum operates a little bit differently. There isn't a formal renewal, and so that one is an ongoing policy. There are some anticipated rate changes, which will take place in the middle of 2026. But for 1/1/26, there's no renewal per se. When we do get a little bit closer to that rate action on June 1st, there'll be more discussion to be had, and largely around member communications and what their options are going to be at that time. For Canopy or EAP provider, they renew off calendar year as well. And so that renewal is July 1st of 2025. And so this time next month, we will be presenting to you their proposed renewal. And depending on how that conversation goes, we might be in a position to ask board members to vote on that renewal. If not, we can postpone that until March. So I'm not seeing any questions. So if we want to jump to the next slide, this is a quick update on the decisions that the board made in June or so of last year for the 2025 plan year. Where we landed were some program changes, some very moderate plan design changes, with reserves making up the remainder, to ensure that number one, the 3.4% cost cap increase was met, and number two, the Providence Choice and MODA plans continue to be low-cost plans. And so, as we work through these renewals over the next few months, a picture will start to emerge on what the projected costs are going to be for 2026. We don't know what that is at this point. Earlier in Emery's utilization presentation, he commented on how the experience is running, but we haven't done cost projections for the following plan year. And so obviously, once we get there, once that picture starts to come into focus, if the composite is above 3.4%, we'll need to go through a similar exercise and talk about what is the most balanced and strategic approach to achieve 3.4%. There's a lot of discussion that will go into that if we need to have that discussion, but at this point, we just don't know. Okay, let's jump to the next slide, please. This exhibit is a longitudinal comparison of these 4 data points. And so we've shown you this in previous years, and it's sort of interesting to look at how PEBB compares more broadly to the commercial insurance market for employer-sponsored health plans. And so I'll just give you a quick orientation. In blue, this is the annual change in employer health benefit cost per employee. In purple, we're showing overall inflation. In green, we're showing workers' earnings. So these are not PEBB worker earnings. This is sort of a nationwide benchmark. And then in pink, we're showing what the PEBB composite annual cost increase is year over year. And so if you compare workers' earnings in green against the blue line, showing how healthcare costs are changing for employees, you can see that in most years, workers' earnings are coming in below the blue line. And so what that means, and this is no surprise to anyone, is that affordability becomes a little bit more challenging every year where that's the case, where workers' earnings are not going up at the same rate that healthcare plan costs are going up. And so there's a positive story here for PEBB. PEBB, as you can see, for the most part, has achieved 3.4% in annual cost growth for the benefits program. And so that's great. Affordability is one of the key values of the board. And as you can see here, it is largely being achieved. I want to pause there and see if there are any questions. And I see, Emily, you have a question in the chat.
Yeah, sorry, I wasn't quick enough.
Oh, that's okay.
Yeah, just seeing the Unum star, the pink star, and then I think in a previous meeting I had asked about how they are able to turn down members' application for life insurance if they have just pre-diabetes but no other condition. And then I was just struck by, Sarah speaking earlier today about how CDC isn't recognizing pre-diabetes in the context of GLP-1 drugs for diabetes, et cetera.
Mhm.
So just wondering if there was any more information about that. And I can totally follow up offline too.
No, that's okay. That's a good question. And I'll be honest, I don't remember what the guarantee issue rules are for the Unum long-term care plan. So if someone on the Mercer team does, please chime in. I thought that there were some of those rules, but obviously if you're electing that coverage after your initial opportunity, those guaranteed issue rules are not going to apply. So if no one else on the Mercer team remembers those rules, what I can do, Emily, is find out and follow up with you.
Okay, sounds good.
Yeah.
Thanks.
Yeah, no problem. Okay, I see, Sarah, your response. Thank you for providing that perspective from the pharmacy side. Okay, not seeing any further questions. Let's jump ahead to most of the meat of the presentation today, which is really talking about 2026. And so, as we've done in previous years, this process is going to play out over the next few months with final rates approved in either May or June, depending on how the largely depending on how the composite cost increase comes in. But we are targeting May, and we'll talk about the timeline a little bit later on in this presentation. As I mentioned, this renewal is happening concurrently with our efforts around the medical and pharmacy RFP. And so one of the ways that factor is influencing how we're working on this renewal is to approach this renewal trying to optimize existing solutions that are in place today and to maximize engagement and improve outcomes and all the other things that we're trying to achieve within the current suite of programs and point solutions, as opposed to looking to explore new subcontracted point solutions. And so given that we don't know how the RFP is going to play out, we don't know who the selected carriers will be for 1/1/27, there's reluctance to add new subcontracted point solutions for 2026, given that unknown in 2027. There's still going to be lots of opportunities to evaluate program changes, look for opportunities to make care more efficient, just not through those subcontracted point solutions, given the RFP that is playing out concurrently as this renewal. I want to pause there and see if there's any comments or questions on that piece before I proceed. The other comment I'll make before I jump to the next slide is that, similar to the RFP, the goals of the renewal are driven by the board's core values. And so we've listed a concise version of those here on this slide with these 4 bullets: equity, improved quality, maintaining affordability and achieving the 3.4% required cap, and enhancing the member experience where possible. And so if we can jump to the next slide, what we've done is we've taken those core values, which are now on the left in that column in purple, and created some key questions that can be used as a decision framework when we get to the point in a couple of months where we're asking the board to make decisions on optional program changes. And so this is one of our work streams where we are asking the board to vote on lots of optional program changes, more so than most of our other work streams. And so we did want to pose some potential questions that you can keep in your back pocket to help evaluate some of these optional programs. And so these, again, are really built on the foundation of these core values. And so some of the key questions we've drafted include, just at a high level, does a proposed change advance one or more of these core values? What is the member experience of a given program change? Does this change address a known inequity? Is it inadvertently creating a new inequity? How does this change fit within the goal of maintaining affordability for members and maintaining the requirement to achieve 3.4% or less cost increase? How does a proposed change fit within the broader medical and pharmacy RFP strategy? And how does a proposed change impact other entities within the healthcare ecosystem in Oregon? And so these are example questions. This is not a full list, of course, but the optional programs that we present to you are usually not black and white. Usually there's a lot of nuance, and so having these questions and having a framework through which to evaluate these programs, we think will be helpful. And so, if there are other questions that folks want to add to this now, that please feel free. We will bring this forward again as a tool as we start evaluating specific optional programs. Okay, let's jump to the next slide, please. For these next few slides, we are going to talk about COW, which is the Strategies on Evidence and Outcomes work group. And so we want to get you oriented to how PEBB's participation in COW is going to fit into this renewal process. There are two sort of key responsibilities that COW handles. The first being carrier renewal evaluation for anything that has clinical considerations. And so we've included some of the focus areas that we know will be highlighted in this 2026 clinical renewal effort. The first is around point solution performance management. I'm going to say more about that in a couple of slides. Women's healthcare is another priority topic that's been identified. There are a lot of known gaps and inequities across the continuum for women's healthcare, and so there should be a rich opportunity here to provide some enhanced coverage and fill some of those gaps. And there will be other topics as well, either those that we have asked the carriers to respond to via the renewal letters or those the carriers have proposed. If there are nuanced clinical evaluations that need to happen, those two will be discussed in COW. The second major responsibility is around the summer research work groups. These are opportunities to carve out space for really complicated topics that require collaboration across sort of all parties, board members, staff, Mercer, carriers participate as well. And so we've included some examples of work that has been done previously as well as is ongoing in these work groups. And PEBB has participated in each of these three topics, the first being GLP-1s for weight loss, doula coverage, and traditional health workers as well. And so the topics for the 2025 summer research have not been identified yet. There's a couple that are sort of being, the tires are being kicked to see if they're a good fit for these work groups. So more to come on that. These are the two key responsibilities. But again, just as I know we've spent some time talking about this over the last few months, just as a reminder, CL really largely is focused on a clinical evaluation, largely related to the renewal, but some other efforts as well, which I'll discuss in the next few slides. We want to jump to the next slide. I can do this one really quickly. This is really just to call attention to the fact that there's a collaboration that will occur between the Health Equity Work Group and CL. And so part of that clinical analysis and evaluation that happens in CL will include a health equity evaluation component as well. And so, you know, this is not really a new process per se. You know, for PEBB, for the last several years, we've had a heavy focus on leaning on our partners in the Health Equity Work Group to evaluate renewal decisions. And so we're continuing along those efforts, but there'll be more integration now between the Health Equity Work Group and CL specifically. And so CL will make recommendations to each board independently, PEBB and OEB. Part of that recommendation will be based on the health equity analysis that was presented in CL. And so that recommendation will be based on the discussions that happened around clinical considerations as well as health equity implications of a given proposed change. So that's not altogether different, like I said, from what we've done in previous years. We have the health equity screening tool that the work group will run more complicated and impactful program decisions through. As well as some other tools that will get used as well to really shine a light on what a given change means from an equity perspective. Okay, not seeing any questions. So let's jump to the next slide. I think we're doing pretty good on time. Okay. So this is another evaluation that CL does every year on behalf of both boards. In the next few slides, we're going to look at the actual results for these clinical quality performance guarantees for the PEBB medical plans. But we largely just wanted to bring this to your attention so that you're aware this work is happening. These results were presented to CIO in early January of this year. But this is an important part of the vendor performance management strategy as well as our measurement strategy. And so again, this is going to be a pretty high level summary of those results. But we did just want to make sure that the broader board was aware of this work and have some discussion and allow you all to post some questions based on these results. And so the way that this performance guarantee works, the carriers submit data to NCQA, which is the National Committee of Quality Assurance. I think I got that right. The NCQA will then send back HEDIS scores expressed as a percentile compared to a benchmark. And so the way that the carriers, PEBS carriers, achieve points for this performance guarantee are in that box in the middle there. 1 point if on a given metric they've achieved at least the 66th percentile, 2 points for the 75th, and 3 points for the 90th. And so again, this is something that we do every year, and it is a living and breathing performance guarantee. This does change from year to year, similar to the other guarantees. As of, I think it's 1/1/25 and not 24, we shifted administrative PGs to behavioral health network access PGs. And so really across the service level agreement umbrella, these change from year to year. Some of those changes in this instance are sparked by NCQA itself. Others are initiated by the carriers or Mercer or staff or other clinicians who are involved in this work. So I feel like that was a mouthful. I see, I'm sorry, Emily, I missed your comment, so let me just read this real quick here. Yes, oh, I see Ali responded. Thanks, Ali. Yeah, I think that's a good idea for discussing, if that'll fit as a summer research work group.
Thanks.
So, feel free to post questions on HEDIS. I know for a lot of folks, this is not sort of the area that we work in a lot. So if you have questions around the methodology or how to interpret these results, please pose them. I am going to hand it over now to my colleague, Dr. Ian Chuang, who's one of our senior clinical consultants on the Mercer team. And Dr. Chuang is going to take us through these next 2 slides, which attempt to summarize the 2023 results related to these quality PGs. So Dr. Chuang, if you are on, I will pass it over to you.
Thank you, Andrew, and good afternoon, everyone. Yeah, so HEDIS provides, a broadly accepted set of reported metrics, process measures that help assess key care processes that align with the PEBB core values. So the beauty of this is, it's a standardized way of measuring that's applied across all healthcare organizations nationally, and it's something that's very familiar to all entities in terms of how they measure and report. So the next 2 slides kind of list the ones that the PEBB have included in the performance guarantees, and they form the basis of sort of how we take a look at key process measures, recognizing that these are sort of sentinel measurements. Care that happens around these topics here, the assumption is if these rates are well and good, that the rest of the care process is going along as well. So these are sort of, think of it as sort of sentinel measures that are important process measures. So this first slide kind of lists the ones that are broadly chronic condition, standards of care, plus a couple that are CAHPS, the CAHPS measures on patient satisfaction and perspectives and feedback. The green highlight basically means that the particular measurement has met the minimum threshold that was set as the performance guarantee. So as you look across the columns, we see the various plans and sort of the change over time within each plan, as well as comparative differences across the plans. I'll just provide some quick overview. So, the first one is just statin. It's really around cholesterol making sure that those people at risk of heart disease have their cholesterol managed in a way that reduces their cardiovascular risk. This one is adherence. Later on, there's one that's on receiving therapy. We couldn't fit it all on one slide. The next one is sort of appropriate care and utilization. Obviously, following a mental health hospitalization, we don't want that person to fall through the crack, not follow up, and potentially become ill again in a significant way. Readmission is very important because if we've cared for those individuals well in the hospital and we send them home, they shouldn't come back quickly within a 90-day window, for example. And again, statin is there for cardiovascular in addition to diabetes reason. And then we get into some of the prevention for chronic condition like eye exam for diabetes. So let me pause there. You can kind of see some of the rates. The comment I will provide, with regards to these performance measures for chronic condition standards of care is, there's not a consistent trend over these 3 years, right? So in the spirit of process improvement, what we want to see is year-over-year incremental improvement. It doesn't have to be a lot, but we always want to see directionally going in a favorable way. We kind of have sort of some bouncing around, right? So, some opportunities to kind of understand that better and find ways to improve on that. Next slide. The remaining measures that we have cover the preventative care elements predominantly on this screen. So we have the couple around immunization, the early childhood immunization bundle or combo, as they called it, and then later on, the booster shots for adolescents. And then the next few are around, obviously, the cardiometabolic and identifying concerns with children and adolescents that may be starting to show concerns with weight and cardiometabolic health. So making sure that they have access and start that process to address. And the last few are around the screening tests for cancer, breast and colorectal, the hemoglobin management optimization, trying to get the hemoglobin A1C as low as possible, and then the remaining statin one for diabetes. So I will say that the cancer screenings year over year across all the plans have sort of incrementally been improving over time. The other thing from a process improvement that we want to look at is if we start to see a plateauing, right? It begs the questions, so why has that improvement sort of slowed down or stopped? Possibly it's because we are missing connecting with certain demographics of the population, and we want to understand that. So there's some initiatives and proposals in the renewal, for example, of kind of being more targeted in our messaging, be more proactive in the outreach. So basically doing what we can to continue the continuous improvement process and the continuous improvement of these measures over time. Questions on these? That was a quick sort of run through. Back to you, Andrew.
All right, thank you, Dr. Twang. Yeah, and so these results are one of many sources of questions that we pose to the carriers in the renewal process if we are seeing something that we want to explore a little bit more. And so again, just wanted to make sure board members you're aware of this work. And I think if there are no questions, let's jump to the next slide. Okay, and so this effort around point solution management is also going to happen in CIAO. And this is part of our ongoing effort to enhance the vendor management strategy for PEBB. And so as board members, as you all know, there are a lot of third-party subcontracted point solutions that are a part of the medical plans today. And we'll talk about exactly what those are and what they do here in a slide or two. But this is our acknowledgement that we want to bring more active management to the performance of these subcontracted solutions. And so the way that we are doing that is we've created a really robust data request template have shared that with our carrier partners, and we are in the process of gathering that data to, again, understand how effective these solutions are, how is engagement, how is ROI, if we can do that calc, how are health outcomes being improved. We've got some health equity data requests in there as well. And so this is really intended to be an iterative process. And so right now we're gathering data, we'll evaluate that data. Depending on that analysis, there'll be some discussion with CIO around improvement opportunities, and then we're going to iterate and we're going to do it again. And so the way that we're doing this year is to really sort of narrow the focus of which point solutions we're going to bring to CIO for discussion. The reason for that is there's too many point solutions to try to do them all in one year. And so we are going to be bringing the behavioral health point solutions to CIO for evaluation this year. Behind the scenes, Mercer and staff will be collecting data on all the other point solutions and starting the evaluation process for those as well. Behind the scenes, this time next year, there will be a new clinical area that will be selected to be put in front of CIO. And so maybe this time next year, we're looking at the musculoskeletal point solutions, or maybe we're looking at tobacco cessation or any of the others that that we'll show you here in a slide or two. So let's jump to the next slide. And this is just a reminder, like what are these point solutions? Why are we using them today? And so these solutions are typically hyper-focused on a specific condition. At times they have sort of a unique approach for engaging members and driving improved outcomes. There are pros and cons, frankly, to looking to implement one of these subcontracted point solutions. While they are hyper-focused, they might bring an innovative approach to a given condition or member experience. There are lots of considerations around integrating with the broader health plan, member communication, engaging with members. Is there robust reporting of these solutions? So it's not always a straightforward evaluation, but there are certainly instances where there's value to be had from partnering with one of these subcontracted point solutions. We've included a couple examples here: diabetes management, behavioral health, weight management. There's lots of other conditions that have these point solutions as well. This is really a space that has sort of blown up over the last 5 years or so in terms of new entrants that are trying to tackle and address specific conditions in a new way. Let's jump to the next slide. This, again, I already sort of talked about this. Behavioral health will be the focus for CIO this year for the 2026 renewal. So we have listed out what those solutions are for PEBB on the right under those lights that make me think of a detective grilling someone. So that's going to be our focus for this year. But again, behind the scenes, the other point solutions will have their data collected, and we'll start to look at the effectiveness of those as well. And next year, we collectively will determine with your input what the focus should be for 2027. We jump to the next slide. This is just a quick overview of sort of the universe of point solutions that touch the PEBB medical plans today. So as you can see, there's a lot. So to attempt to create a dashboard and facilitate meaningful discussion around all of these in one go through CIO didn't make a lot of sense. Hence our approach to sort of curate this, create bite-sized chunks, starting with behavioral health, and then moving on to some of these other areas next year, depending on what we're seeing in the data that we're collecting this year. And so that will be a discussion that will be informed based on the data that we collect between now and the next month or two. Any questions so far on that effort or on CIO in general with regards to how those meetings will interact with our renewal efforts with the broader board?
No questions about that. Just wanting to call your attention to the time, Andrew. I know you know.
Thank you. Thank you. I was keeping an eye on it earlier, Don, and I had sort of forgotten. So thank you. We're almost there. We got a couple more slides. Let's jump to the next slide, please. This is a summary of some of the topics that we included in our round one renewal request to the PEBB carriers. And so the way this works is we will put together these very lengthy renewal requests, share them with the carrier partners. After they work on them for several weeks, they send us back the round one renewal responses, which we recently received and we are currently going through and reviewing. And so we wanted to give you a little bit of a flavor for some of the items included in round one. This is not an exhaustive list, but you can see we've got some requests around utilization data, some preventive benefit options around cancer screenings, as well as women's health, some pharmacy items around GLP-1s and biosimilar strategies, some questions posed around performance guarantees, around health equity and behavioral health, network access, timeliness to appointments, that sort of thing, as well as some other requests that didn't neatly fit into one of these categories. Jump to the next slide, please. This one has a lot of information. We've tried to make it digestible by breaking it down into these 3 rows. And so in that top row, renewal activity, this just shows what work is happening in a given month. And so right now, in the second half of January, we are in receipt of the round one renewal responses. We are doing our evaluations, posing clarifying questions to the carriers, that sort of thing. We will present those findings to CIAO first in early February, and then we will present those responses as well to the board later in February. After the board meeting, we'll draft our round 2 renewal requests and start the whole process over again as we work to refine, what strategies does PEBB want to pursue for 2026. With this calendar, we do have May as the month that we are trying to achieve approval of final rates, which would mean that final benefit decisions are voted on by the board in April. Maybe we can hit that timeline, maybe we can't. There is a little bit of wiggle room if something comes up that requires us to spend another month talking about the nuances of some of these optional program changes. So know that is there as well if needed. And then the next slide is sort of just a simpler view of this somewhat busy renewal timeline. If we could jump to the next slide, please. So when we meet this time next month, we will be talking about the preliminary proposals from carriers. At that point, we will also have a summary of how the initial CIAO clinical discussion went on those proposed changes. And so that always makes for a good discussion. So looking forward to that. And then we will continue to work through that and refine it in March. We'll incorporate some of the other benefits as well, other than medical and pharmacy. We'll talk about dental and vision, some of the ancillary coverages as well, with May as our target month for approving final rates. Apologies for speaking a little bit quickly there at the end, but I think I got through the key points I wanted to. Let me just pause. I know we're over time by 2 minutes, so let me just pause and see if there are any questions on any of that.
My only question is just more of a comment. Do we need a formal vote to move to CIAO? I mean, I know we might lose people on this call, so just want to make sure we do that if we need to do that.
Yeah, but it should just take like 1 minute, 2 minutes tops.
That's where we're headed. Hearing no questions about this, let's go ahead and transition. Thank you, Andrew and Mercer team. Glenn, may I invite you to speak briefly about the CIAO frame of this vote that we need to take, please?
Yes, thank you, Dawn. Basically, in October, we came to the PEBB board and asked them about participating in a joint CIAO work group. And there were no specific concerns. However, we did delay the final vote till December, waiting for the OIB board to vote on this, and they voted yes. So really, we just need kind of a formal vote from PEB to indicate that they would participate in really expanding CIAO to a joint PEB-OEB work group. Then the second part of that would just also be, because we're moving to a joint work group, we've expanded to 6 members, 3 OEB, 3 PEB, and we have 2 PEB board members currently participating, but are in need of a third person.
We actually have Kimberly as volunteered, Glenn, is the third.
Oh, okay. Sorry.
Yeah, thank you, Kimberly.
So
Perfect.
I would like to make a motion that we formally join the CIAO work group with OEB.
I can second that. Greg?
Thank you, Greg. All in favor, say aye, please.
Aye.
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 It's
Thank
Chicky, aye.
you. Chicky. Thank you. Any opposed? And with a unanimous vote, that is an approved motion. Thank you, board.
Thank you.
Thank you, everybody.
Before we close, I'd like to bring to your attention that we do have one public comment about concerns that lifetime caps for health insurance may become legal again. Please do take a moment and look that over, board members. Thanks to PEB staff and our Mercer colleagues for today's content and all the work you do behind the scenes, including connecting with our members to make sure that their input is really helping us drive this work where it needs to go. Anything else for the good of the order? Hearing none, gratitude to all of you for participating with us today. Thank you very much. Have a beautiful day.
Thanks, Don. Thank you, Siobhan. Take care.
Thank
Is
you,
adjourned.
everybody.
Bye-bye.
Mhm.